Good afternoon, everyone, and we'd like to welcome you to Improving IBD Care, a Personalized Approach to Management. If you are Twitter followers, this will be, you can converse at GIHFAIBD17. And to connect to our network, we will be available by plugging in your passcode AIBD 2017. The connection then you'll go to, and you have the tablets in front of you. So the tablets you can send questions to us on directly. You'll find our disclosures in your handbook. This is a CME program, and it's supported by unrestricted educational grants from American Region Incorporated and Pfizer Incorporated, and we appreciate their support. So I'd like to introduce my colleagues, Dr. Maria Abreu from the University of Miami, and Dr. Edward Loftus from the Mayo Clinic, Rochester, Minnesota, and we have in plan for you a terrific program. Okay, so let's start now with the case, and we'll see if we can hopefully improve how people have done over time in understanding those questions. This is a classic case you might see in the office. So this is a 24-year-old male who has new onset of bloody diarrhea. This patient was well until 4 months prior when he had gradual onset of bloody diarrhea. He's now having 5 bowel movements a day, most of which have blood within them. There's urgency, no nocturnal awakening to defecate, and no fecal incontinence. He's related that he's having mild abdominal cramping with each bowel movement. He has no extraintestinal manifestations present. The past history is that there's asthma, no allergies to drugs. His mother has had ulcerative colitis diagnosed at age 37. Socially, he's never smoked cigarettes. He drinks 6 to 8 beers on the weekend, and his symptoms impact his ability to exercise and socialize, but he can still work despite these. He's got an examination that's notable for he's well-developed, well-nourished. He has no oral ulcers seen. His abdomen is soft, non-tender. There's no hepatosplenomegaly or masses. His extremities, he has no rashes. His erythrocyte sedimentation rate is normal at 15. The CRP is normal at 5.4. He is not anemic. His hemoglobin is 14.1. And the comprehensive metabolic panel notes normal electrolytes and normal liver-associated chemistries. He had a sigmoidoscopy done, and this showed continuous symmetric involvement from the anal verge to 50 centimeters. And there was a decrease in the vascular pattern, as you can see here. There's really no visible vessels. Friable contact, there's erosion at adherent mucopus. It was a Mayo endoscopy score 2. And the biopsies were consistent with active chronic colitis. No granulomas, no viral inclusions. Stool for enteric pathogens, and C. diff was negative. So when treating IBD, we look at several things, obviously: the disease severity at presentation, the clinical, the biologic prognostic factors that we have in patients. Achievement of clinical and biologic remission is really something we attempt to do, and then we try to maintain that. We focus on patient adherence, therapeutic monitoring, and pharmacoeconomics obviously play a role as well. When we look at patients directly upon presentation, we have to say, are they a high or a low risk for colectomy? And this is something that will dictate the current therapy and the future therapy that we employ in an effort to better gain under a state of well-being. So if they have limited anatomic extent and they have mild endoscopic disease, for example, a Mayo 0 or 1, if you would, these are individuals that have a low rate of colectomy. If they have extensive colitis, such as pancolitis, deep ulcers, young age under 40, high CRP and biomarkers, they have steroid-requiring disease at their initial presentation, they've been hospitalized, they have C. diff or CMV, These are actors that say this individual has a high risk of colectomy and aggressive therapeutic intervention is needed at the onset. If we look at recent pathways from the AGA that have been set forth based upon the best evidence we had at the time, those with low colectomy risk, we can start with mesalamine, topically, orally. An MMX budesonide or prednisone might be considered in topical steroids, and then we'd maintain them with mesalamine either orally, topically, or in combination, and get rid of the steroids, tapering them over the course of a couple months. If the patient has no remission in that scenario and they don't go into a state of remission, we cross them over to the high colectomy risk patient directly. Or if they present initially with a high risk based on their risk factors, we then give them steroids at the outset. We might initiate a thiopurine. A biologic should be introduced, whether it's an anti-TNF, an anti-integrin, with or without immune modulators, and then maintain them on the appropriate agents, the thiopurine with or without the with the biologics. And then if they don't respond and don't have remission, then we switch the biologics. We escalate dose if it's something that's an anti-TNF or shorten the interval, and we can escalate the anti-integrin from every 8 weeks, perhaps every 4 weeks, knowing this is off-label, but it's been shown to work directly in clinical practice. And if they all fail, then colectomy. So getting back to this patient was given oral mesalamine, topical mesalamine in the form of an enema, 4 grams and 4.8 grams. After 3 weeks, the symptoms improved, but they didn't resolve. As a result, budesonide 9 milligrams MMX was started. And 8 weeks later, the patient came back saying symptoms got worse over the last month, and he's now getting worse with 9 bowel movements a day. There's blood in the stool, urgency, incontinence, coming to wake up in the evening 1 to 2 times, and has moderate abdominal pain, as well as severe fatigue, which is really incapacitating and making it difficult to function. The examination is notable for, he's tachycardic now, dry buccal mucosa, tenderness in the left lower quadrant. The fecal calprotectin is high at 782. We'd like to be below 50 just as markers so you can get an idea. The SED rate's high, the CRP's reasonably high, 15.4, and he's now anemic. Hemoglobin is 10. CMP is such that the albumin is 3. So this is a sick patient getting worse, not improving, rapidly before your eyes. The sigmoidoscopy is very remarkable. As you can see on the left side, there's deep ulcers, spontaneous bleeding, no normal landmarks that you can see, and the biopsies were consistent with severely active colitis, no viral particles were seen, no CMV was evident. So the current issues this patient has now are, 1, the active inflammation, 2, the anemia, 3, we'd like to talk about preventive strategies and health maintenance, and these are the things we're going to focus on, at least at the outset. So I'd like to turn this over to Maria to focus on this and to discuss this case.
So Gary didn't make this guy better, so he had to come to Miami.
Good place to be.
And so we're following on this poor kid who's getting rapidly worse and what we should do. So this is, I think, a very pretty diagram. Hopefully you'll have access to these slides when we're done. And I'll, for now, focus on the left-hand side of this slide on the stuff that we have mostly available at the moment, or at least the strategies that we have available at the moment. Until not so long ago, until not so many AIBD meetings ago, we had anti-TNFs or anti-TNFs or anti-TNFs for the treatment of ulcerative colitis, and we've listed for you in order of how they were approved: infliximab, adalimumab, golimumab, which, as you know, the way I explain it to patients, are antibodies that block the bullets of the inflammatory response, sort of one of the last effector molecules that has a directly inflammatory damaging effect on the epithelial lining. One step before that, though, one could try to intercept some of these inflammatory cells before they actually make it to the intestine by, as I like to describe, blocking their GPS, blocking their ways. And we could do that with vedolizumab, which is approved, and etrolizumab is in clinical trials, and I won't be discussing that any further, but nevertheless, it's working by a similar mechanism. And so this guy's sick. We decide to give him 10 milligrams per kilogram at the outset. Pretend for the moment that insurance companies love you and they don't mind approving 10 milligrams per kilogram. In other words, we're in Disney, so you can suspend belief. And I'll describe to you a little bit why. I mean, the guy's sick, the guy's hypoalbuminemic, and we'll see why we sometimes have to ratchet up the dose in patients like that from the beginning. You give them 2 doses as close together as you could manage, again, getting insurance approval for. And then you give him another one 4 weeks after that second dose. And he comes back to see you about 10 weeks after you first started on infliximab. In other words, you want to see this guy pretty quickly, maybe even more quickly than 10 weeks. He feels well overall. He's had some improvement in his symptoms for sure. His physical exam is normal. His CRP is slightly better than it had been. Not quite normal, but again, slightly better than it had been. So I want to tell you a little bit about how we, from the outset, try to be proactive about therapeutic drug monitoring. And so this is a diagram that represents for us what happens when we use monoclonal antibodies as treatment for our patients. In the black bar, in the black line, the more Space Mountain line, is what happens when we give an intravenous anti-TNF or an intravenous anything. There's a peak, it comes back down, you give another big dose, it goes back up, it comes back down. And in the middle, in that blue little sort of gray shaded area, there's the little bobbling of a subcutaneous dose. Because in a subcutaneous dosing, there's more kind of continuous exposure and release, right? And the deal is that we want to keep some juice in the tank always. So we've put that gray line or that gray rectangle to represent that we want to have some gas in the tank at all times. We don't want people dropping below that, whether it is with infusions or with subcutaneous dosing. And why don't we want that? We don't want that because then if we allow the tank to be empty, we allow the inflammation to come back, even if it isn't clinically apparent. And then every time you're giving this patient a dose, you're retreating the disease instead of maintaining remission. Hopefully that makes conceptual sense. Moreover, one of the very best ways to immunize a patient towards any biologic is to have this roller coastering where at the trough, the patient has fallen to a very low level. Because then every time you give this dose, you're basically saying to the body, look, here's this foreign protein again. Whereas the immune system has a default pathway that if you keep some protein around all the time, it goes into this, again, like the default pathway of not developing antibodies against it. So this is, there's a sweet spot that we want to achieve. And so some of the reasons that went into choosing a higher dose of anti-TNF from the outset for this particular young man is that there are factors that are correlated with protecting against getting rid of the anti-TNF and factors that increase the drug being eliminated. On the left side of this slide is the use of concomitant immunosuppressives. We can have a whole session on why we use concomitant immunosuppressive medication, but at least one big component of it in the era of biologics is to keep stable, steady, higher levels of the biologic. Then there are factors that increase drug clearance. Once you've made antibodies against the drug, those antibodies start targeting it for destruction more quickly. Patients that have low serum albumin, it's basically a surrogate marker for protein-losing enteropathy. So they're pooping out the anti-TNF in this case, or the antibody, any IgG antibody. High baseline CRPs, there's a bigger inflammatory burden, and therefore there's a lot of target. You need a lot of the drone to hit that target. And having high baseline TNF concentrations, having someone who's overweight, and I believe not only overweight, but with central adiposity, which is very inflammatory. And finally, male sex, which we can do very little about from my experience, and this guy happens to be a man. So We've chosen to show you the data from this particular paper, this Papa-Michael paper from Adam Shafis's group at Beth Israel Hospital and also from UPenn. And the reason that we've chosen is because it fits my bias that we should be proactive about measuring trough levels. In this study, at the BI, Adam, and I don't know if anyone else besides Adam, had preordained that he wanted to keep his patients at trough levels of anti-TNF between 5 and 10. Other people in his group didn't have that as a practice. They just sort of followed them clinically. These data are only looking at what happened to ulcerative colitis patients. And on the y-axis is treatment failure. So a higher line is bad, a lower line is good. So what you can see is, in the dotted line, those patients that had reactive testing really had a very high rate of treatment failure, whereas those patients that had been followed and have proactive monitoring had a much lower likelihood of having treatment failure. Why might that be? Well, the first is I'll call your attention to the fact that on the bottom left of this slide is detectable antibodies against infliximab. And what you can see is for those patients that had reactive testing, they were much more likely to have ATI. Now, it's a little bit of a circuitous argument because they probably had an infusion reaction, were losing response, and therefore they had reactive testing, and ergo they had antibodies against infliximab. But by then it's too late. You can't intervene in any way. They also were more likely to have infusion reactions, but perhaps most importantly, the really sort of black and white data are that they had more hospitalizations and more IBD-related surgery when you just let them come back and tell you, oh, I'm losing response. All arguments, I think, for proactive testing, but Ed doesn't like that, but you know, he's on that side of the island.
We'll talk about it later.
This is a little bit of a seizure-provoking slide, but just listen to me, and maybe this is really for me to be reminded to tell you that there are various ways that one could do therapeutic drug monitoring. I happen to like to check trough levels before the first maintenance dose, whatever that drug is and whatever that first maintenance dose is, okay? And at that point, you can say, oh, look, the levels are super high and they're doing awesome. You can downregulate and de-escalate what you're doing for that patient. Like this guy got 10. If he kept getting 10, maybe his level's going to be very high. Or, man, it's perfect. I am so awesome. You can leave it there. Or, the level is low. I just heard a talk. I went to AIBD. I wanted to get a free lunch. This woman said if they're below 5, we should try to increase the dose, right? And you increase the dose for that next dose that the person is getting, or shorten the interval, whatever it is that makes you happy. And then, of course, all these other things might happen. You might discover when you check levels that the patient has developed antibodies against the drug. Now there, it's a little bit of a gray zone, because if the level of the antibody against the drug is sort of low, and I don't know if it's on the slide because I'm not reading it so carefully, I dose escalate and add an immunomodulator, okay? On the other hand, if the level is already really high, and maybe even the person had an infusion reaction, you're kind of done. And then you're left to decide, do I change to another anti-TNF because they did really quite well initially on the anti-TNF? That sounds like a good strategy. Or, you know, really, they didn't do that well from the beginning. Let me change mechanism, okay? And along the way, if you've made, I'm going to say the mistake, or if the person showed you with the first biologic that they like to make antibodies against the biologic, please don't let them have monotherapy on the next round, right? That would be a little silly. Those are patients that have already flagged themselves as needing to be on a concurrent immunomodulator. Okay. Dose optimization in severe UC. This is a recent paper, but basically the data are limited, but where the field has sort of gone naturally is trying to compensate for the fact that the sick ulcerative colitis patient is pooping out their anti-TNF. You give it to them, and just like the albumin is disappearing in the stool, likewise, all the immunoglobulins are disappearing in the stool, non-specifically, and along with it is whatever anti-TNF, or I should say whatever biologic you have them on. For that reason, there have been some case control studies that have used dose intensification of the infliximab This is primarily in the inpatient setting, but you try to approximate this also in the outpatient setting, where you've given a couple of extra infusions in the first 3 weeks, and that can be effective at trying to keep someone's colon, okay? So this is still a bit in flux, but the point of the story is that we want to hit them hard at the beginning, sometimes giving infusions of infliximab every few days in a hospitalized patient. So that was talking about really kind of the anti-TNF alone, but we know that there's a benefit to combining and adding a thiopurine to the treatment of an ulcerative colitis patient, and that's based primarily on this SUCCESS trial, which is the mirror image of the SONIC trial but done for ulcerative colitis, and in this study you can see that patients that were on combination therapy with azathioprine and infliximab did better than infliximab alone. So far you've given this kid infliximab alone because he was really sick. Now he comes back to see you, and you decide, look, I really need to throw the kitchen sink at him, right? Because the guy's going to be losing his colon. The colon's going to be in the path lab soon if we don't do something. We check his TPMT enzyme activity. It's normal. You start him on azathioprine on the sort of adequate dose. His trough level of infliximab is 8, kind of exactly between that 5 and 10 mark. But 3 months later, you do another sigmoidoscopy, and again, you find that he has active disease, and he's having, really, for someone who's now on combination therapy, good levels of the anti-TNF, really doing unwell. So what would you do next? I think the kind of the monosynaptic reflex now would be to try another biologic from a different class, right? Because you've had adequate levels of the anti-TNF. What should that be? That should probably be vedolizumab. And you can see that we've chosen to show you the data for the 52 weeks, okay? It works, obviously, in 6 weeks is the first data point that is in the New England Journal of Medicine paper. This guy is on the left-hand side of the slide because he's a guy who's actually had prior anti-TNF exposure, and therefore they never quite look as good as the virgins on the right-hand side of the slide, but nevertheless, it's pretty good, okay? So you choose for him to give him vedolizumab. It's dosed similarly to infliximab in terms of timing, 0, 2, and 6 week infusions. And, I think he does well. I thought that was going to be the next slide, but just keep that in the back of your mind. What if vedolizumab didn't work for this guy, right? What's on the horizon? So I want to spend just a couple of minutes describing to you what's on the horizon for our patients. And actually, at least for one of these, probably very short on the horizon. In the yellow boxes are 2 other novel mechanisms of treating ulcerative colitis, JAK inhibitors and CYP1 agonists. JAK inhibitors, the JAK pathway, Janus activated kinase pathway, it's an enzyme pathway that works like IKEA pieces. There are various different JAKs, 1, 2, 3s, and they pair in different combinations. And these are receptors for many different cytokines. And what happens is, say you have interferon gamma. Interferon gamma binds these JAK receptors and activates a cell to say, go forth and make mischief, make pro-inflammatory cytokines. By having something to block it at a very early step in the pathway, you can turn off a lot of different inflammatory signals, a lot of different cytokines simultaneously. So what has been invented are these small molecules that fit into the groove of these proteins to shut them off, okay? And because they're small molecules, they can be given orally. So tofacitinib, which is commercially available for the treatment of rheumatoid arthritis at a lower dose, has been tested in clinical trials for ulcerative colitis, and I'll show you that. The CYP1 agonist on the right are molecules that tell a lymphocyte, come inside the lymph node, little boy, come inside, and then it keeps them there, okay? It traps them in lymph nodes. This is a strategy that has been successful in the treatment of multiple sclerosis and now is being usurped for the treatment of ulcerative colitis. These are the data on TOFA. This was published in the New England Journal of Medicine around May of this year. You can see that on the left, even at 8 weeks, there's a huge separation, even by 8 weeks, of people receiving tofacitinib at the dose that's going forward in the clinical trials of 10 twice a day. And even remission at 8 weeks, which is really kind of a very striking thing. And in other exploratory analyses, even within days, people have seen a drop in people's diary, reporting of having symptoms. So I think this is something that hopefully will be part of our armamentarium and works quickly and orally. And then these are the 52-week data. Let's just focus on one thing, so it won't be so many things that you're looking at. Let's just look at remission, which is the second set of bars. And what you can see is that, of course, at the end of 52 weeks, a third of people are in remission. That's fab. But in addition, I'll show you that the 5 milligrams twice a day is really very similar to 10 twice a day, so that in some patients, I think we might even be able to de-escalate the dose of the medication. I'll call your attention to the fact that one of the signals in the clinical trials of tofacitinib, but that's probably a class effect of these JAK inhibitors, is an increase in the rate of herpes zoster infections. So you can see that with 5, and at a higher dose, there is a dose-related effect of increased herpes zoster infections. Ozanimod, which again, cousins of ozanimod are used for the treatment of multiple sclerosis. These are New England Journal of Medicine data from last year. At week 8 is also very effective in the treatment of ulcerative colitis and is going forward in clinical trials, but is not quite as ready for prime time as tofacitinib is. So now in follow-up, you've started him on Veto. He does great. 4 months later, when you see him, as Gary said, his fecal calprotectin is normalized, his SED rate has come down, his CRP has come down. His hemoglobin, however, is still at 9. His tank is still empty. His albumin has come back up, and he's still complaining of fatigue in spite of the fact that you've made his GI symptoms significantly better. So I'll turn it over to Ed to tell us how he would manage his anemia.
Thanks, Maria. Some of you may have been to some of the sessions earlier. We heard Corey Siegel talk about patient-centered care, and the gears have shifted in this patient. This patient is no longer talking about their bowel symptoms, they're talking about their fatigue. And one of the most common causes of fatigue in IBD patients is anemia. It's also important to remember that now anemia, or addressing anemia, is considered a quality metric by several different organizations, including the CCF. And some of you may have heard, give me the others.
Oh, sure.
Clicker. This one
There you
isn't
go.
working. Okay, thank you. You've heard that, there's a Crohn's and Colitis Foundation pathway, a care pathway for anemia that we'll talk about a little bit later. So I think it's important for us to address fatigue in our IBD patients, and again, anemia is going to be the most common cause. In fact, I would argue that fatigue is one of the most cardinal symptoms of IBD patients. We tend, as gastroenterologists, to focus on the GI issues, but don't forget about the fatigue. Far and away, the most common form of anemia in IBD patients is iron deficiency, although because of the chronic inflammation, they can also have anemia of chronic disease. In patients, not so much with ulcerative colitis, but patients with Crohn's disease, you're going to see vitamin B12 deficiency. Don't forget about folic acid deficiency, which can occur in our patients on sulfasalazine or perhaps methotrexate. And then some drugs can induce anemia, including sulfasalazine and the thiopurines. And then there are rarer forms of anemia in our IBD patients. Don't forget about autoimmune hemolytic anemia, which can rarely occur in our ulcerative colitis patients, myelodysplastic syndrome, other drug-induced causes of aplasia, and then just unusual hemoglobinopathies or other disorders of erythropoiesis. So I'm going to walk you through this semi-complicated cartoon of iron distribution, and in honor of Halloween, we've made it a little bit spooky for you here. So the average person takes in about 18 milligrams daily of dietary iron, but of that, only about 1 or 2 milligrams are absorbed from the duodenum. And the form of iron that is mobilized throughout the body, sort of the transfer system, if you will, is through plasma transferrin. That transports it to the different places. About 1/6 of the iron is employed in the muscles in the form of myoglobin. About 2/3 are employed elsewhere, including the bone marrow, in circulating erythrocytes in the form of hemoglobin, and also in the reticuloendothelial system in the form of macrophages. And don't forget, there's a large amount of storage of iron normally in the liver. And it's normal for the body to lose in an average person about 1 or 2 milligrams of iron daily. So you're taking in 1 or 2 milligrams daily from the duodenum, but you're losing 1 or 2 milligrams because of sloughing of cells, desquamation, menstruation, other forms of blood loss. Now, hepcidin. This is an important point to make in our IBD patients. Hepcidin regulates iron homeostasis and specifically iron absorption, and in inflammatory states, hepcidin is increased. This is a small 25 amino acid peptide. It regulates iron absorption and how it distributes to the tissues. It's made in hepatocytes. Again, its production is increased in inflammatory states. This small peptide binds to ferroportin, which then causes the ferroportin to degrade. And ferroportin is the protein that allows iron to go from the epithelial cell into the bloodstream. And again, hepcidin is increased in inflammatory states. And here's an example. On the left, you see normal hepcidin levels. The iron is absorbed from the lumen, it's in the cell, and then it gets exported through ferroportin into the bloodstream and then into the normal distribution throughout the body. But in increased inflammatory states, these increased levels of hepcidin cause increased degradation of ferroportin. So the iron gets absorbed, but it's trapped in that cell and it can't get out and get mobilized into the blood and into the rest of the body. And so you have actually paradoxically decreased iron absorption in these pro-inflammatory states. And it's been demonstrated that hepcidin levels correlate with the presence of IBD and also with disease activity. This is a study of about 200 patients, half of whom had IBD, and of those half had UC, half had Crohn's, and then the other half were healthy controls. And the median hepcidin levels were higher in the UC and Crohn's patients versus the healthy controls. And then in ulcerative colitis, disease activity correlated positively with the serum hepcidin level. You can see the R value was 0.36, but the P value was highly significant at 0.009, and this also correlated positively with C-reactive protein with a P value of 0.004. However, serum hepcidin correlated negatively with ferritin fairly strongly there. You can see a very low P value. So again, when you're working your patient up with anemia, the standard initial labs should include a CBC, a ferritin, an iron saturation, C-reactive protein, creatinine, and reticulocyte count. If you can't figure out the anemia based on that, you need to look at other causes, things like vitamin B12, methylmalonic acid, folic acid. If you're looking for hemolysis, you want to check a haptoglobin and an LDH. And in some cases, you're going to have to refer the patient for bone marrow biopsy. And again, I think as an IBDologist, this is something that you should be initiating. You shouldn't just say, oh, it's anemia, I'm just going to refer to hematology. You should at least start the process. And I don't really refer to hematology until I'm down at bone marrow aspirate. I think this is your responsibility to do. I'm not going to do the bone marrow aspirate. Okay, so again, looking at that same cartoon of the iron distribution, the big difference in IBD is that you have a block at the absorption level, right? Because of that hepcidin is not allowing the iron to leave the cell to go into the bloodstream. And there's also a problem with just mobilization of the iron in general from the reticuloendothelial system, from the macrophages back into as plasma transfer. And so the patient becomes sort of functionally iron deficient. So what about oral iron? Well, this is a good first step, and I think it's considered a standard step because it's been around for a long time, established safety, it's low cost, it's easy to administer, and I think in patients with inactive IBD, patients that are quiescent in remission, this is a reasonable strategy. However, there can be issues, and we'll talk about that in a second. I think the most widely used iron supplement is ferrous preparations, but we'll talk about some of the other options. I think the problem with oral iron is that at higher doses, you tend to see more gastrointestinal side effects. And of course, in an IBD patient, this is problematic. They already have gastrointestinal symptoms, and then you're piling on with the oral iron. So you can see in up to 20% of patients, nausea, vomiting, diarrhea, abdominal pain, constipation, dark stools. There are a number of parenteral iron products on the market in the U.S. The first one we have is iron dextran, which has been around forever. This is approved for general iron deficiency anemia. A test dose is recommended because of the risk of anaphylaxis. It's given generally over a long period of time. You can give a large amount at once, but it may take multiple hours to give that, and then the patient has to be observed afterwards. Iron sucrose and furosemide are options. These are technically indicated in patients with chronic kidney disease. Iron sucrose can be given quickly, usually given in relatively small amounts at a time, so it requires multiple injections. And then on the far right, we have ferric carboxymaltose, which is indicated for general iron deficiency anemia, and it can be given as a slow injection or infusion over 15 minutes, and then there's a period of about 30 minutes of observation afterwards. And you can give up to 750 milligrams of ferric carboxymaltose at once, and so it's a relatively large amount in a short period of time. Here's an example of a study comparing ferric carboxymaltose to oral iron, showing that patients achieve their goal faster, and then look at the bottom with a much lower rate of adverse events that resulted in discontinuation of the product. So you get to your target quicker with fewer side effects. In the Crohn's and Colitis Foundation care pathway, Gil presented this morning. You have the patient present with symptoms including fatigue and bleeding. You should get the hemoglobin and ferritin, and that helps you place the patient. Are they iron deficient? Do they have anemia? Or do they have both? And then what you do is you kind of diagnose the patient. Are they somebody who has adequate iron stores, in which case their ferritin is above 100 and their transferrin saturation is above 20%? Meaning it's not iron deficiency, look for other causes. Do they have iron overload, meaning their ferritin is very, very high? Ferritin can be confusing in this inflammatory state because it also acts as an acute phase reactant. That's why you really need to look at both the ferritin and the iron saturation. But then you have the patients that have low ferritin and low iron saturation, and those are the patients who are indicated for iron therapy. So once you've decided to give the patient iron, you have the option of oral versus IV, and in the Crohn's and colitis care pathway, it's suggested that patients with inactive IBD could be given oral iron up to 100 milligrams daily of elemental iron, but patients with active IBD, it's suggested to go with IV iron because it's going to be better tolerated and it's actually going to be absorbed for all those reasons that we mentioned before with the hepcidin and all that. You could also consider hematology referral. You assess the patient after you give the iron in 4 weeks, and hopefully you've seen an increase in the hemoglobin of at least 2 grams per deciliter. If you haven't, then you should be escalating therapy. So if they're on oral, you should go to IV iron, or you should consider hematology referral. If the patient has responded in 4 weeks, you should probably repeat another hemoglobin in 4 weeks to make sure that the anemia has resolved. If it hasn't resolved, you should again consider escalating iron therapy. If the patient has persistent fatigue despite normalization of iron stores, you should think about other causes of fatigue, such as B12 deficiency, hypothyroidism, et cetera, et cetera. You should also monitor the patient's hemoglobin on an ongoing basis. So getting back to our patient, he received a dose of ferric carboxymaltose, 750 milligrams after his vedolizumab infusion, and then subsequently received a second dose 1 week later. And then 1 month later, he reported resolution of fatigue, and his hemoglobin was up to 13.1. So now that he's better and his issues have been addressed, now you have a little bit of time to think about some of the health maintenance issues that are relevant to IBD patients. And so I'm going to hand this over to Gary and let him talk about those issues.
Thanks, Ed, for setting this up, because now really we have to recall health maintenance and also remind people, don't forget to send your questions up. If you have cards there, please hold them up if you want to submit them, or by the keypads. And health maintenance is a very important aspect of care for patients with inflammatory bowel disease. Not only is it related to therapy monitoring, but also cancer screening, as you heard in the session recently, depression, smoking cessation in both Crohn's and ulcerative colitis, bone health, and vaccination. And I'm going to touch on some of these directly and focus on things. The agents we use to treat patients, we obviously monitor laboratory parameters. We look for infectious issues that may come about, corticosteroids being the main drivers, but also the anti-TNFs, thiopurines, neoplasia, congestive heart failure associated with the anti-TNFs, bone mineral density, immunogenicity, and also hepatotoxicity directly. So whether we have monotherapy or combination therapy, the immune responses are normal compared to those people that we do not have treatments with. And these are things that we need to focus on directly. There's some recent guidelines put forth by a group of us in the American College of Gastroenterology. Dr. Ferre is the first author, and those are very good reference points. We have articles referred to on the slides. So let's look at some of the things. So the inactivated vaccines, the DPT, all patients should get that, and you don't need to check titers before. Hep A is recommended for all as well. HPV for the select populations. It's female, male 11 to 26 is the current recommendations, but you might extend those depending upon the individuals. The influenza vaccine, not the nasal spray. The nasal spray is a live virus, so don't use that. The influenza is a dead attenuated virus. Neisseria meningitis and strep pneumonia are all recommended, and there's no pre-testing for them recommended. Hep A, you need to check pre-test before, because if someone has been exposed, they don't need the vaccine. The live virus, the live attenuated viruses, we have MMR, varicella, and zoster. And zoster I'm going to talk a little bit more about because we have a recent development in the past 2 weeks or so. The FDA approved the dead virus vaccine, if you would, the attenuated vaccine, which we'll talk about. So MMR, if you have unknown vaccination history, check a titer, as is with varicella as well. And if the patient's already on immune suppressant therapy, you can't give MMR, and varicella depends on the type of the immunosuppressive agents, as does zoster. With zoster, you can give it if it's on patient on azathioprine or prednisone less than 20 milligrams a day for 2 weeks. Those are the current ID Society of North America recommendations directly. The recombinant zoster vaccine, it's very exciting. It's FDA approved for individuals under the age of 50, or over the age of 50, and those people that have immune suppression, this should be considered as well. It's over 97% effective for people over the age of 50, and as reference, the attenuated live virus has been reported in the 50-60 range directly. So this is a much more effective vaccine directly. And you can see the numbers there, placebo versus a recombinant, the effect on the zoster vaccine, looking at the incidence per 1,000 person-years of herpes zoster, shingles if you would. Osteoporosis screening is important. The conventional risk factors for patients with ulcerative colitis should be included in assessment of patients, and then it shouldn't be measured any more than every year to 2 thereafter because the variation in the reading of these. The bones should be assessed in individuals that have more than 3 consecutive months of 7.5 milligrams of prednisone based upon the best evidence we have. So low-dose prednisone can alter bone density, and it's something to be cognizant of because we can alter the fracture risk by treating patients directly with the bisphosphonates and appropriate therapies based upon their findings. Depression is very common. We've heard a lot of this meeting about depression, 15 to 35% based on the series. It's obviously worse when patients are sicker. So when you have active disease and patients have other issues in life, screening is important. And some simple questions you might ask. Over the past month, have you felt down, depressed, or hopeless? Over the past month, have you feelings, little interest of pleasure in doing things? And we ask these to all our patients directly. Our nurses ask them, and then we ask them directly. Even in endoscopy, when we're doing endoscopic procedures, it's part of our standard to do that within the health system. And we really identify many patients that are depressed and need interventions directly. We also ask about abuse as a problem, as a routine through our health system on a standard basis. And it's surprising to see people you wouldn't expect have answered these in a fashion that they need some intervention and help, and we offer that to them at the time. Cancer screening we're all cognizant of as well. Colorectal cancer surveillance after 8 to 10 years for those with extensive disease or left-sided disease. PSC, remember, that's at the time of diagnosis. Do every year surveillance in that population with chromoendoscopy, as Ben suggested, and there's new ACG guidelines coming out for ulcerative colitis and Crohn's at the early part of 2018 that should highlight those. Melanoma, non-melanoma skin cancer, once you've used azathioprine 6-MP, your risk persists despite cessation of medication. So these patients need continued monitoring every year, every 2 or more frequently, dependent upon their findings. The anti-TNFs have a higher risk of melanoma, and Ed has published data. Patients with IBD themselves have a higher risk of melanoma based on a meta-analysis he performed. So advocate to do skin exams, not necessarily yourself, by a qualified individual, whether it's a practitioner or a dermatologist, because you may not recognize things in the hair, behind the ears. Things are the places they typically wouldn't do examinations in patients in the office. Cervical cancer is higher on immune-compromised patients, so remember, check for that. So hopefully in this discussion we can show that early aggressive treatment is important according to the patient prognosis versus the symptoms. The symptoms really are a part of the overall equation, and we treat based on objective parameters. Our goal is to prevent a loss of a response that patients have. We not only want to achieve a response, but attempt to not lose that response once we've achieved it. We assess the loss of response and the mechanisms. Parenteral iron is often needed to overcome the poor absorption we see when there's active inflammation in patients because of the elevated hepcidin. Remember, as Ed discussed, the hepcidin goes up in states of inflammation. It's an acute phase reactant, if you would, and that blocks ferroportin from absorbing the iron. So consider the parenteral iron. And health maintenance is an important part of what we do, so pay attention to that and remember to discuss with your patients, and if you don't do the health maintenance directly, refresh their memories and have them go to their primary care providers.
Oh, great.
Okay. So now we have a couple questions. Remember, send your questions in, and I'll ask the first one to Maria. Why anti-TNF and azathioprine instead of anti-TNF methotrexate, given the patient age, male gender, and risk of lymphoma?
Yeah, we had more than one question from you about that, and I think it's a very valid question. I think for the sake of brevity, we didn't go into that aspect of it. He is a 24-year-old young man. We worry about hepatosplenic T-cell lymphoma in that age group. He was failing, or we're concerned about him failing monotherapy with an anti-TNF. If you remember from the very beginning of the case, he had like 8 beers a day. And he's a 24-year-old guy. So methotrexate is also not fabulous, because you're afraid he drinks perhaps a little too much, may, when he's drinking, do other things that he shouldn't be doing. And so we chose to put him on azathioprine. We should have mentioned, or I should say that I would be checking also his EBV status. You may know that for patients that are young, like less than 30, the ABV status should be checked because we would not begin a thiopurine in an ABV naive person because there's an increased risk of hematophagocytic HLH, which can be fatal in patients that are on a thiopurine at the time that they become exposed to EBV. So, he's at a tricky point. I think it has a lot to do with your patient. I have young women that are 24 years old, and I would not hesitate to give them methotrexate because I think they're very responsible. Whereas I have, young men that are the same age, and I may not be so interested in giving him that.
So Maria,
That sounded
or,
politically incorrect, and I'm
yeah.
sorry.
So did he use low-dose azathioprine or high-dose in a person
Yeah.
typically? And when do you choose low-dose versus high-dose?
Yeah. So we had a paper a couple of years ago with Andres Yar as the first author describing that levels of thiaguanine of above 125 were sufficient to lead to an increase in infliximab levels. And in other words, you didn't need to have full throttle azathioprine or 6-MP in order to see the beneficial effect on the biologic. Having said that, that was in a group of patients that were in remission and were maintained in remission. I think that this part you'll have to decide for yourself. If you have someone really sick and you want to throw the kitchen sink at them, you might want to, at least at the beginning of therapy, have them on full dose and then de-escalate the thiopurine. At least in maintenance, you certainly don't need to have full throttle levels of thiaguanine.
So Ed, how do you look for maintenance of hemoglobin over time? How often do you check in patients, and what's your strategy? Do you check iron studies, hemoglobins, or what should they be doing?
So for my, let's say my IBD patient who's not on a thiopurine, I'm getting a hemoglobin, and they're stable. I'm
Right.
getting a hemoglobin on them at least once a year, and typically when I get that hemoglobin, I routinely check iron studies. So I'm checking iron studies once a year. I think the prevalence of iron deficiency and fatigue is high enough in your IBD population where that justifies checking that once a year.
Can you differentiate iron deficiency from iron deficiency anemia and say a difference between that? Is there symptoms that come about with iron deficiency and not iron deficiency anemia?
No, I mean, I think you can see a fair amount of fatigue, symptomatic fatigue in patients with iron deficiency. Just because their hemoglobin is normal doesn't mean they're iron deficient. So any workup of fatigue, don't be fooled by a normal hemoglobin. You got to check the iron stores to know if they're iron deficient. And I can think of so many patients where we repleted their iron and it had a significant impact on their energy level. So it's worth looking into.
And the other thing is restless leg syndrome is very common
True.
as well, and that can lead to fatigue as well. Any particular labs we should use for monitoring? When you'd mentioned monitoring, Maria, do you use a certain one a certain way, or are they all pretty equivalent and the operating characteristics reasonable?
You mean therapeutic drug monitoring,
Yeah.
Gary?
The question comes, is Mayo as good as Prometheus, as
Right.
Different
ARUP as
assays,
opposed to
okay.
The different
LabCorp and
assays, yeah.
others that have the different labs?
Yeah, that's a good one. I think, we all are faced with the fact that the patients, can't afford to be paying for really very expensive labs that are not covered by insurance plans. Hopefully this is not going to come out as any bias, but I do want to share with you that if you don't already know, that Janssen will pay for 2 Maraca anti-TNF levels for patients that are on infliximab. And so I try to use those judiciously, and the patient can have them drawn at Quest. So it's kind of a nice thing that you can send them to Quest and they'll draw the Maraca labs and they won't get a bill. And that's twice a year. So you might consider, for example, in my scheme, a trough level at the first maintenance and then a trough level some other time months later to document that they're still doing well, or if you need to do it reactively. I think that any test that measures the drug and measures the antibody, as long as you follow that in an individual patient, you're fine. I think anything is better than nothing. And at the end of the day, what we know most clearly is that you have to have drug at trough or the patient is not going to do well. And we can quibble about what that perfect level is, but we can't, because it probably has everything to do with the individual person. Do you disagree?
Yeah, so I was just going to say, you just need to know your assay. I mean, the
Yeah.
drug levels, the actual drug concentrations tend to, and there was a nice poster that Janssen did that was at ACG a couple of years ago, and they showed that with the different assays, the drug levels all pretty much correlate with each other. It's just the antibodies are also different because they're different methodologies, different units, and so the antibody with one assay is often very, very different from the antibody level with another assay. So you just need to know your assay to know how to interpret it. And I totally agree with Maria that what may be a seemingly therapeutic drug level for one patient may not be enough drug for another. So I have to say that in my practice, if the patient isn't fully dose escalated on the biologic that they are on, I will dose escalate before I will give up on the drug because it's a, quote, therapeutic level. I think that's the most common mistake I see when patients are referred in. So even if the level was, say, 8, if the patient wasn't fully optimized, before I would give up on that drug, if you saw some response, I would dose escalate. The only time you shouldn't dose escalate is when the level is 0 and they have high antibodies.
Right.
That's when you definitely know you need to switch.
And the issue is there's no publications on this, so it's really more just trial and see how patients do. The last question, and then we'll close. Ulcerative colitis this patient had, should we have used methotrexate to treat the active disease? Is there good data for that? Anyone?
So there's a European trial called the METEOR trial that was published that technically missed its primary endpoint, but it made some of the secondary endpoints, and we're also waiting the results of a CCFA Clinical Research Alliance sponsored trial on methotrexate in UC. In my own practice, I do use methotrexate in UC. I think it can work in a subset of patients, and so methotrexate to me is a legitimate alternative.
Yeah, and in that trial, those that were steroid dependent didn't do well, but those who were naive to steroids did better. So that might be a population to look at per se. To keep on time and to allow you to go to the meeting, to go back again, we'd like to thank you all for attending. We'd like to thank our sponsors, American Region and Pfizer, and of course the GI Health Foundation. Remember to hand in your evaluations, please. Thank you much.